All right, so Harold, last time we left off, we sort of built up to what was really your first experience doing ECT and how much of the decisions you made at that time, including titration, set the stage for what would come for decades to come as far as ECT technology. So I want to pick up from there and really talk about what were the most important developments in ECT since you really started these innovations, and also thinking a lot about both not just the efficacy but the side effects, right, which are often discussed in the context of ECT.
Thank you, Marom. The efficacy of the treatment in large part is unchanged from the early days. When we were using very ineffective treatment and treating well above the seizure threshold, that did not compromise the efficacy of the treatment. What it did is it totally aggravated the cognitive side effects of the treatment. And as I indicated last time, one way of looking at it is that in the days in which sine wave stimulation was being used bilaterally, the average time it took somebody to know their name the day of the week where they were was about 8 hours following a single treatment. Nowadays, the average with, let's say, ultra brief right unilateral ECT is 7 to 10 minutes, right? So that's, and that change in the acute cognitive effects was mirrored in the more persistent and to the patients more concerning cognitive effects. So, sort of to put it in a nutshell, ECT in the 70s, in particular, was studied by the neuropsychologists extensively because it was a profound laboratory for the understanding of memory. It was an ECT that people like Larry Squire, who became president of the Society for Neuroscience and one of our great memory researchers, he came up with the distinctions between propositional and non-propositional memory, between episodic and non-episodic memory, declarative and non-declarative memory. Those are essentially all in the same types of comparisons, but he came up with them in part through the study of patients getting ECT. And what was true in ECT was that when you came in for this treatment, you were intentionally impaired very often. Depressed patients, for instance, have often marked difficulty in taking information in about the world. Because if you're so focused on your ruminations and your depressive ideation and affect that it's hard to attend. So if you give the depressed patient a list of 10 items and ask them to tell it to you back, they'll report back immediately less than a person who isn't depressed. However, if you ask the depressed patient 2 hours later to tell you what was on that list of 10 items, the percentage they will report will be about the same as somebody who isn't depressed in terms of what got in. So what gets in stays in before you get ECT. ECT has the inverse effect on new learning and memory to the extent that it improves your attention as you get less depressed, but it interferes with retention of information over a delay. That's called anterograde amnesia.
Which is
Right?
short term, though. That
Yes,
that makes it a short term. The
no
benefit is
matter how you
even.
do ECT, that deficit in learning and retaining new things lasts maybe 2 weeks, 1 week afterwards, and so on. It's never really been demonstrated to last more than a few days. And it clinically is very important because you don't want to go out driving, you don't want to be making important decisions when you can't retain information over delay. It disappears. Um, but that was one aspect of the memory deficit. And there, again, Squire's work was very important because Larry showed, for instance, that if you teach depressed patients mirror writing, sort of the equivalent of non-propositional, non-declarative memory, where, it's like learning to ride a bike, there's no deficit after ECT. What they've learned stays in. And so, and there are different neural systems that mediate these types of memory. And so you can see how important ECT was in terms of our beginning to have an understanding about how memory is organized in the brain, what the essential features of it were. But clearly, patients were reporting another type of amnesia a loss of memory, which was more concerning to them and in many cases more persistent. And that was the loss of memory for events in the past. And many of the greatest critics of ECT were people that would say, you know, I lost 5 years of my life. It was just a blank. I don't have access to it. Uh, and it was very clear from a scientific point of view that, in fact, if you presented information just before the ECT treatment and tested for its retention afterwards, that much of that information was vulnerable to loss. And for instance, if it was verbal information, the loss was greater with bilateral than with right unilateral ECT. But for spatial information, it was greater with right unilateral than left unilateral. That sort of thing. That was an important mediator.
But I can tell you a quick anecdote about that. I had a family member. She was a young woman, and ECT, say she was extremely depressed, and as with many people, ECT basically saved her life. And she was recounting a story where her mom would drive her to her treatments, and they would be chatting in the car, and then she would get her treatment. She'd be walking home, and she was saying it was funny. One time, her mom was saying she started to bring up a conversation, and it was the same conversation they'd had on the drive over, and she was kind of telling her we already had this discussion. So. All right, so transient, and short-term deficits are there. Um,
But in the retrograde area, there clearly were people that were saying that they were not transient, they were permanent, and in some cases quite extreme, that years of their life was missing. And that became a highly politically contentious issue for ECT, in part because the psychiatric profession, which certainly in the 70s and 80s and so on, with things like Cuckoo's Nest and the anti-psychiatry movement, particularly the Church of Scientology, got very defensive about this treatment. And in the absence of objective evidence of persistent amnesia, essentially claimed that this type of side effect was not rare, but didn't occur, that all of the cognitive effects of ECT were transient. And that was common in terms of what was being presented to patients. And particularly since my work was in ECT was funded by the National Institute of Health. And our job was to sort of tell it like it is. We spent a great effort in terms of developing techniques that would objectively measure the loss of memory for events in one's own life. And to give you a sense, in the first studies we did on this, we developed questionnaires that took about 3 hours to administer to depressed patients, asked about 300 questions about their lives, got 300 details about each patient's life, which we verified with a family member by asking them independently the same interview beforehand. And we did this with normal controls as well. And to see what the magnitudes of deficits were, and so on. And these would be things like, what was the address at your job, not currently, but the address of your job before last? What was the telephone number? What did you do last New Year's Eve? Who were you with? What was the trip you took out of town, the trip before last? On and on and on. We had asked positively valence things. What was the best thing that happened to you in the past year? What was the worst thing? And to look at whether there was any valence to what memories were lost and so on. And we were particularly interested in whether there was any association with the patient's own experience of memory loss. What were the patients reporting themselves about memory? So put it in a nutshell, when we did the work introducing titration, what became obvious was that many patients in the old days were being treated, if they were using the same electrical waveform, let's say a brief pulse, many were being treated 50 times their threshold or more, 60, 40, 60, 50 times their threshold, because there's great individual differences in seizure threshold. The amount of electricity you minimum need to produce a seizure varies markedly across people. And because everybody was getting the fixed dose at the top of the machine, those with low thresholds were being dosed greatly over. That immediately, low dose treatment from the beginning was clearly less impactful on cognition in all respects, including the acute effects that you saw in terms of orientation recovery or performance on neuropsychological tests right around the treatment, short-term effects, but it also turned out in long-term effects.
It's such an important point. I just want to kind of clarify it, right? So you could have one group of people that are just getting the maximum on the machine.
Right.
Um, they are getting the ECT is still producing a seizure in them, and they are getting the benefit. You have another group of people where everyone is being titrated, and so therefore no one's really at the top of the machine. They're getting less electricity. They're still getting a seizure. They're getting the same benefit, but less side effects. And so, does that teach us that the side effects are being caused by the electricity and not by the seizure?
Yes, there is no doubt that the nature of the electrical stimulation has a profound impact on the cognitive effects. May not be, 100%, but it's certainly a great deal. It was all a package to the extent that the disorientation you see acutely following a seizure is, to me, a rapidly shrinking retrograde amnesia. The things that come back first are the things you've learned earliest in life. And the things that come back last are the things that you've just learned, like the day of the week or where you were and so on. And you can see in ECT, particularly with the old forms of treatment, that if you ask somebody how old they were immediately after treatment, they would wake up and they say they were 20 when they were 70, and they would age in front of you. They might be speaking their first language. And the psychoanalysts would call this regression. But the neuroscientists were saying this is a rapidly shrinking retrograde amnesia. And so when you do that at each treatment and you don't have full recovery from a treatment, you could be producing a retrograde amnesia that's persistent and more extensive in its past. So that for me was one of the reasons why it was wonderful that the uh, period of disorientation was a biomarker for what your memory would be like 6 hours late, 6 months later. And so you could always clinically adjust the stimulation parameters with that in mind. And that's what we teach nowadays. But we were fortunate. The National Institute of Mental Health funded a study uh, in which we looked at ECT outcomes at 7 hospitals in the New York City region, not including Columbia. It was not a site. So we had research assistants at these 7 hospitals testing each patient before the ECT, during the treatment, and again 6 months later. And that study, there was a paper in Neuropsychopharmacology in 2007, which was um, called Cognitive Consequences of ECT in Community Settings, which essentially showed that how you were treated, where electrodes were put on the head, what the dosing patterns were, determined how persistent your cognitive side effects were. That, for instance, bilateral ECT was associated with much more loss of autobiographical memory than unilateral ECT. And that essentially in stimulating the brain, we had control over the magnitude of these events, not just immediately, but months later. What was also consequential, that was one of now a set of studies that showed if you ask patients originally, has ECT done bad things to your memory? As a group, patients say, no, it's done good things. And the extent to which they say it does good things co-varied with your depression scores. The extent to which it said ECT did good things to patients, believe that was co-varied with their depression scores. The more you had a clinical benefit, and so at one point, we were actually in consent forms that were being recommended by the American Psychiatric Association for ECT said, however, a significant number of patients believe ECT has improved their memory, right? Because that's essentially what they were saying. And they were saying things like this on the Squire Memory Complaint Questionnaire and Broadbent's Cognitive Failures Questionnaire. It turned out another contribution we made was to simplify things and say, let's just ask patients for their global impression that ECT hurt or help your memory, as opposed to asking much more atomistic questions like, do you have trouble reading road signs? Can you concentrate on a book? Which is how the other questionnaires went. When we asked a very simple question, does ECT help or hurt you on a Likert scale? The majority of patients said it hurt, as opposed to help. And more consequentially, the other questionnaires did not co-vary with any neuropsychological objective performance, whereas the global impression, the simple one, correlated strongly with patients' neuropsychological test scores, but in particular, most strongly with their degree of amnesia for autobiographical information.
Like being, you need to believe the patient, believe your patients when they tell you things. Yeah.
Yeah, exactly. So, if anything, I mean, this is a wonderful story in the history of ECT because the magnitude of the side effects, which was one of the biggest rate limiting factors. ECT used to be, in the very original days, over half the patients, their treatment was prematurely stopped because they were so confused. Their memory was so bad that the treatment actually couldn't be conducted. They weren't recognizing family members necessarily. Nowadays, I mean, I've had patients where we've treated them and they've appeared on Broadway that night. So a whole different level of experience for the patient in terms of impact on cognition.
You mentioned before that there was some, especially when you were starting to do ECT, there was maybe a reluctance among many practitioners to admit that there were these cognitive deficits, and it's almost because of your willingness to admit they were there and measure them that you sort of then had the opportunity to improve on the technique to make them go away, right? Those two things had to go in hand. You sort of had to be very willing to embrace the benefit and the risk in order to then be able to optimize those, to titrate those out.
Right, I think absolutely right. That why would you want to reduce, the parameters of the treatment, soften the electrical impact, unless it was consequential, and the area that it clearly seemed to be consequential was in terms of memory. And for the field of brain simulation, this is to me, one of the really outstanding examples of the extent to which the parameters of stimulation dramatically impact on cognition. I mean, we're struggling as you know, clearly, Marom, to identify manipulations in brain stimulation that will enhance cognitive performance. That's the goal. But we have this incredible track record of knowing how much we could interfere with it going the other way. Just one other comment on that, and ECT is certainly not frozen. In 2000 and I think it was in 2008, we reported the first major randomized trial of ultra-brief stimulation. And that was essentially showing the same point. With ultra-brief stimulation, all we did was we took the pulse and we shortened its width, right? So we compared, all of our work before then had used a 1.5 millisecond pulse width. It was right in the range. The devices were giving between 1 and 2 milliseconds, right? And so we were right in the middle and we were titrating with that. We said, I thought, if our understanding is that the chronoxy for getting a mammalian neuron to fire is between zero point 0.1 and zero point 0.2 of a millisecond, why are we giving a pulse that's an order of magnitude wider?
Mm-hmm.
And would we have lower thresholds for seizure by going to an ultra brief stimulus? And again,
Lower charge threshold.
lower charge, right? Overall lower charge. And so we randomized people to a study in which there were 4 conditions: bilateral ECT 2.5 times the seizure threshold, which is the highest you ever go with bilateral because the side effects become unacceptable above that, particularly with a brief pulse. And then right unilateral ECT at 6 times threshold, because we had already established with brief pulse that that's what you needed to make unilateral as effective as bilateral. But we didn't know for the ultra brief what would happen there. And the brief pulse was a 1.5 millisecond stimulus, and the ultra brief was a zero point 0.3 millisecond stimulus, so a 5-fold range. And what we found is that seizure thresholds on average were 3 to 4-fold less in terms of charge with the ultra brief than the brief pulse. That we didn't totally make up the fivefold difference, but almost.
Yeah.
And so it was clear that the wider pulse was inefficient.
From a
Uh,
charge perspective, what about from a uh,
from that
treatment or side
perspective,
effect perspective?
if we take, for instance, time to achieve full orientation, it was a third that you
Hmm.
got with it, so that it would typically for the brief pulse bilateral, it was about 45 minutes. It went down to 15 minutes. It went from 30 minutes for the unilateral six times threshold brief pulse down to about 10 minutes. So it was a third the time it took. And that was totally reflected in how much memory loss there was for events in one's life. Essentially, those orders of magnitude of difference. There are very large effect sizes between all of these things that were totally modulated by the nature of the electrical stimulus.
So,
So ultra brief, for instance, right, unilateral in many places in the world now is the default treatment. That's where people will start, and if it proves not to work as well as one would like, then they have the options of switching to other forms of ECT. And to finish that story, we just finished a randomized trial in Prague where we compared a zero point 0.15 millisecond pulse width, which we call ultra brief,
hmm.
to zero point 0.3, and people were crossed over at the first. They were titrated twice, and the point at 15 had lower charge associated with it and was more efficient in producing seizures again. So getting closer to the Carnaxi for ECT is probably a wise idea.
It's interesting, correct me if this is right. I mean, you're basically were saying as far as efficacy, even the most antiquated form of ECT might have been as effective as what we have now. And so really the research on ECT in the modern era hasn't really focused on necessarily increasing potency or efficacy, but rather just reducing the side effects because you were already starting with such a spectacularly and that is such a spectacularly effective treatment, which is I think unusual. I'm thinking most other fields of medicine,
Very
both are
different
in play.
when we get to TMS. It was TMS had to grow in its efficacy, but ECT had to reduce its side effects. Absolutely, that and we were blessed to have that opportunity to do that. But you can imagine again, this is a context where the patients getting ECT at the Psychiatric Institute had an hour neuropsychological battery at every treatment, a week of neuropsych testing before starting ECT. Then they repeated the whole thing afterwards. Then, if they didn't get well, they got a second course of ECT, and then they were brought back at 2 months and at 6 months and so on. So highly intensive in order to study all these things.
But the single most important thing that changed, right, from let's say not modern to modern ECT was charge titration, which was actually, we talked about this in the last part of this interview, the exact place where you started. So in fact, your very first innovation, your very first trial, adding in charge titration, and then as we talked about, recognizing it's actually different for different montages. That was essentially the most important breakthrough, which is
Yeah, that
and the
was
rest
that.
is icing on the cake.
I would say yes, I would agree, and that's my colleagues like DP Devanon, head of geriatric psychiatry now at Columbia. That's essentially what he said was that the whole kettle of fish started with doing dose titration. That changed our understanding of ECT and how to give it and all that. Absolutely true. That it was all built off of that. And the thing, for other people in science that I think is consequential is that was not part of the grant. That was not anything we were ever really funded for. It was something that we thought would make for better science. That it was the art of doing the better experiment that said, I don't understand this. Let's try it. Why don't we go about it this way? And it was the whole purpose of that first study was a failure, but it obviously had some consequences afterwards.
I agree with that. I think philosophically so much. We have this cartoon version of science that you stare at the ceiling, you develop a hypothesis, and then you just run it through. Where in reality, it's more about these, observations you make in the process of doing something else. Realize it, right? A failed experiment that instead leads to another discovery. Because it's almost like if we knew where to look, well, we would have looked there already, right? It's all about where you didn't know to look.
The
All right.
the
Yeah.
I guess one last issue with ECT, which again I think is very consequential for neuromodulation, is the question of durability. That's sort of the term that's being used most often now for this area. And again, when we started to work in ECT, the biblical view was that uh, if you didn't do anything after ECT, 50% of patients would relapse within 6 months. But if you gave an antidepressant drug, 20% would relapse in 6 months. That was essentially the understanding. And what didn't make sense to me at the time was a couple of things. From the very beginning, we followed very rigorously all of our patients afterwards. And our social workers would call them up every couple of weeks and administer the Hamilton over the phone, and we would track relapse essentially with for the people who had benefited from the treatment. And part of that was because of the feeling of the need to know: do you really go through all of this for a benefit that may last only a few weeks? Or is there some greater lasting benefit that you're hoping to achieve? And if it is, how do you get to having that lasting benefit? One of the things I didn't understand was why we were getting so many patients who failed drugs uh, before coming to ECT who were being put back on the same drugs after ECT that didn't work beforehand. And I also didn't understand why we were seeing so much relapse. And I remember going to truly one of the greats in our field and asking them, how come some of these drugs are not working for so many people? And he turned to me and said, Harold, that's not an ECT problem, that's a drug problem. And our early work developed the first methods to quantify treatment resistance. How potent was the antidepressant regimens you were on or had received in the past? Which were they? How do you categorize them? All that stuff. And we developed one of the things I developed was the antidepressant treatment history form, which is now the most widely used instrument in the world for evaluating the adequacy of antidepressant treatments and so on. So an example is in the current recovered trial of vagus nerve stimulation, the patients in that trial average 13 failed antidepressant treatments historically. They're massively resistant. Um, and so one of the very first things we reported back in 1990, that if you're treatment resistant, your likelihood of relapsing following ECT was twice that than if you had not failed an adequate medication trial before coming to ECT. Right?
There were
And
people getting ECT without having failed a
many people, because some cannot tolerate an adequate medication trial. That was particularly true in psychotic depression, where the dose of antipsychotic you need for it to be considered adequate is often intolerable. Those are sort of the intricacies of the pharmacology there. Or people who were acutely suicidal, had benefited from ECT in the past, nothing else had worked, those sorts of things. So we raised that issue. Does treatment resistance predict? And now we replicated a number of times, and that's now been replicated also in TMS and in other areas that
yeah, I was
in
going to say, right,
treatment resistance predicts treatment resistance both acutely and in the long
right.
run.
To anything, to drugs,
I
to
think, yeah, yeah.
if you're treatment resistant, it's going to be harder and harder to get you to respond.
And for what it's worth, I'm controversial in believing that some of that is iatrogenic, that antidepressant treatment is like antibiotics. Antibiotic resistance is because of the exposure to failed antibiotic treatment. And I think that's also true to some extent with biologic treatments, that they're not neutral in terms of their residue.
I really want to go back to this question you posed, right? Why then do you relapse? Hey, you're better, right? I mean, we see relapse with everything. It's not a uniquely ECT issue. So did you have what was what did
Yeah,
you think of that? Is there an answer to that issue?
it's a complicated story because at the time, back in the 70s and 80s, the biblical view in psychiatry was that depression was an episodic illness that would last for maybe 2 years on average, particularly severe depressions, but would spontaneously remit. That all our treatments were doing, and this I do agree with, was suppressing expression of the episode, right? But the underlying biologic disturbance continued despite that suppression. And if you took it away, the drugs, before there was a spontaneous resolution, you would have relapse. And the early work in England on ECT was some of the most powerful to support that belief, because it truly was a case that if you gave placebo after ECT, about 50% would relapse within 6 months. The other 50 would go on and have great lives. And you could reduce it markedly, 20% with drugs. What at Columbia we were seeing is far higher rates of relapse. That relapse was a huge issue with ECT. And we didn't know what the true underlying relapse rate was because everybody was being treated and so on. So we were funded to do a multi-center study that we published in JAMA in 2001, and which is the only modern study I ever give people placebo following ECT, because we didn't really know what are we trying to improve. In that study, we randomized patients who were remitters to ECT to either placebo, nortriptyline alone, which it was a tricyclic antidepressant, very powerful, effective antidepressant, or nortriptyline plus lithium. And the relapse rates in 6 months were 84% with placebo. Nearly, if you're on after ECT, it's not the 50% from the England, it's 84%. And what is important to realize, and Declan McLaughlin, the chair at Trinity College Dublin, had a wonderful paper in neuropsychopharmacology showing that from the 60s till around 2015, the relapse rates with ECT have increased across time, that there's a secular change. And my interpretation, and there's, I think, a lot of support, is because the patients are more and more treatment resistant. That's the power, that we are selecting for more and more for the people who are going to do badly with the treatment or with relapse. And in fact, the amount of ECT we give in the world has also almost doubled or tripled for many patients in terms of how many treatments they get over time. So when Kalinowski, who introduced ECT to America at the Psychiatric Institute, said, how many patients does a depressed patient need? He was the one who first identified its remarkable efficacy in depression. It was 4. 4 to 6 was the median number of treatments that are depressed. Then it moved up when the drugs came out to 6 to 8, then 8 to 10, and then now it's in the 10 to 12 range in the average. And some patients need, we took a group of patients, we just had a paper in brain simulation on this, where we took a group of patients who failed ECT and gave them a second course. And we had a 70% remission rate. And even when patients got the same type of ECT twice, that basically you need a lot more ECT today than you used to use in order to get people well. And I think that that's a secular change due to the nature of the patient population, the resistance of these people.
And is that because patients have, let's say, other options like TMS? So almost by nature,
And drugs and
once for then making it all the way to ECT there's all these new treatments. So now they have to fail all these to make it to ECT.
Exactly. They had many more options. And when we first did VNS, when we were one of the 4 groups to do the first implants with VNS for depression, my patients at Columbia averaged, I think it was 20 failed drug trials, and all of them failed ECT with me before getting VNS. So you can imagine these are really tough people. So, so it matters who is being looked, when you're evaluating a treatment, you need to know, essentially what have they received before and how much they failed. So from the relapse point of view, what we found essentially is that when you add lithium to an antidepressant, and another subsequent multi-center trial, we added lithium to venlafaxine and had the same effect. That pharmacologically, that's our best strategy. for relapse prevention. It's not great. I mean, 40% is a lot better than 84%, but
In
it's
these very, very difficult patients to
difficult
begin with.
people, right? Exactly. But you can also use ECT itself, and Charlie Kellner's work with the core group has demonstrated that when you add uh, continuation ECT or rescue ECT, you can do even better. And I think true. And in the future, what I'm hoping we're going to see is whether you could use TMS
Or
as
GDCS or something else.
yes,
Right.
yeah, that there are
For
great
maintenance.
opportunities here to promote the stability of the treatment. And but the larger point is, when we did the work with durability with VNS, durability now has become, for some of our interventions, the reason for existence. The reason we're interested in treatment like VNS is not because of not, maybe let's say 40 to 60% will show some degree of benefit after a year to 2 years of getting this thing. But you're not going to go through surgery to get a modest level of improvement unless it lasts. And what the VNS data showed was that for almost everyone, it lasts. It has remarkable durability and benefit, even though they're a highly resistant group. It's sort of like very similar to what we see, I think, with Parkinson's disease, movement disorder phenomena, and DBS, that you get great persistence of the effect in a population that is done very badly with drugs.
So going back to this question of why you relapse, right? The way you're explaining it, and this again is not specific to ECT. This would be any antidepressant treatment is um, you the depression is emerging in episodes, and what essentially you're doing is you're truncating that episode so it's over. However, you have not necessarily treated the underlying disease, and therefore at some time point another episode will inevitably reemerge.
Yeah, many of these illnesses are recurrent. But when I started, to give you the sort of the fuller picture, when I started, it was very common to see people who had a fulmination early in life. They had an acute, severe episode, maybe psychotically depressed. You get them well. And then I saw them 30 years later after they had a great life, and now they had another recurrent episode. And nowadays, so that is where you saw depression is like the flu. It was episodic, and unless you fully treated it. Uh, but nowadays, the much more common clinical presentation are people who've been sick for 10 or 15 years, and they're sort of half well, and they're being frozen in place in many ways with the pharmacologic agents. And I don't know whether they're so our models have gone from being a episodic flu-like phenomena to more like a diabetes phenomena. So that once you're on a drug, you're on the drug for the rest of your life, and the illness is now being conceived as a chronic illness. So much more like congestive heart failure than anything truly episodic. We don't talk a lot in the field as to why our underlying models have changed. And I think it's iatrogenic that oftentimes because where the pharmacology is there. It's not that for many of these, in my own work, I did multi-center work where I showed that if you gave people placebo during ECT, an antidepressant placebo, or venlafaxine or nortriptyline, you started the antidepressants early, you get a 15% improvement in your remission rate with the drugs than you do without them. That ECT benefits from having the antidepressant on board, right? But it's also possible that those drugs are the same things that are preventing the resolution of these episodes,
Yeah, yeah.
right?
What one of the things you're saying so far about, um, the episode, maybe ECT truncating the episode. I understand it's more complicated than that. So now I want to ask you this question really beginning at mechanism, right? What is the therapeutic mechanism? Because generally speaking, right, we know that the all neural brain stimulation works not because the brain lacks electricity, right? And there's like electricity deficit and we're putting it in. I would also say the brain doesn't lack a seizure, right? That's
Yeah,
not why you're depressed.
yeah. I often joke at lectures and say nobody ever got depressed because they lacked a seizure. Right.
So I think, the concept may be more that either the seizure or the electricity itself is activating a process that is built into the brain itself, right? There's a system in the brain that is a very complicated system because depression is extremely complicated and mood is extremely complicated. And either the electricity or the seizure is activating that system in a way that the patient cannot activate it themselves. And then that activation is leading to it. And for me, you mentioned in the last part where we discussed it, how ECT could even treat status epilepticus, which is so weird, right? Why would a seizure treat a seizure? But that would also make sense if the seizure that you are producing activates a corrective process in the brain, an anti-seizure process, right? That then shuts down. So I wonder if you could kind of build on these
Yeah, my modeling has always been that we're wired to be depressed. Very different than my colleague Don Klein, who I mentioned last time, the father of pharmacology, who saw depression more as a deficit state. Right? So is the disturbance in appetite, the sleep disturbance, is it more like an aphasia or a release phenomena? So when you're really thinking circuitry, is the depression where we've produced, like some injury to the brain so that it can't function the way it's supposed to, or is the depressed state itself an organized phenomena involving, many at different levels, cognition, mood, and appetite, and vegetative function, and so on. And I was always the one that believed that both depression and mania are things that you can trigger.
And I would tie that back to the very first part of this interview where you were talking about your early work about trying to understand
Right,
how,
right.
how the brain is juggling, happiness and depression. Go ahead. Yes.
So I'd always thought that yes, and in a very Bowlbian sense, the analyst from England, that essentially the attachment there is. I think that one of the purposes of our being wired to be depressed is it allows us to love. That if we did not experience loss, and particularly in child rearing and in the evolutionary importance of that, how would we have these little things that hang around for 10 years that need all of this nurturing and so on, all the sacrifice, if there wasn't the cost to pay for their loss? And so, whatever its purpose, I think we are wired, and we now are getting into circuit. We're really with stimulation technology. We can see that we can produce manic states and we can produce depressed states, and so the excitement of ECT, because and we haven't spoken about the spatial localization it offered, the what it taught us about circuitry, was that it offered an opportunity to essentially figure out where in the brain do we have to intervene in order to get this antidepressant type effect. My own theorizing uh, came largely out of epilepsy work, where we know in epilepsy you get a surround inhibition at a seizure focus. Um, and that makes a lot of sense because if you have a broken pipe in your kitchen, you don't want to shut off the water that's flowing in your bedroom. You need to shut it off at the pipe, right? So if you have a focus that's the engine for a seizure, where it propagates to may be less critical than where it derives from. And that was exactly my view as what happens in ECT, because all of my work with absolute quantification of regional cerebral blood flow and glucose metabolism and so on, and the EEG work that we did, all indicated that we're getting highly regionalized effects, and in particular lateralized effects with the comparison of unilateral and bilateral. But we were the first to tie antidepressant effects to the impact on prefrontal cortex. And we had paper in '94 in what's now JAMA Psychiatry, showing in, I think it was about 60 people, that the more we drove blood flow down an hour after the treatment in prefrontal cortex, the more people were likely to get well.
I think
In
we'll probably revisit the prefrontal cortex story when we move on to the TMS, maybe in the next part. I really want to. what you're saying is so interesting. So I want to sort of revisit it. So we are wired for depression in the general sense. We could say, our brain has a circuitry that is built to push us in that direction.
Right.
Uh, would you say we have other circuitry that is designed to counteract that, obviously, and produce happiness? And then is it the depression that, what is the depression circuitry too strong? The happiness circuitry is too weak, or is that not the right model?
Yeah, the it could have been a whole bunch of ways. Essentially, you're asking is if you have a circuit that's activated that results or is expressed as depression, is there something else that's inhibiting it, or is it just inhibition within that circuit that's modulating it? And I think there's some reason to believe that there's reciprocal inhibition in the adult between the euphoric states and the dysphoric states. That to me is less critical that they have separate representation. And as we discussed last time, I think there is very little that's phenomenologically different about somebody who is essentially kicked in their soul by their spouse saying they're going to leave them or their employer saying that they're doing a terrible job and so on, and what you see in a depressed patient. I think that normal sadness has tremendous overlap. It's the same circuitry, and what's abnormal in the depressed state is that it doesn't stop. And so that was always in my mind, are we inhibiting this type of circuitry? Was my immediate mechanical view as to how something like ECT was working. The
Stopping an overactive depression circuitry, letting the system reset in a better balance.
Exactly. And that the only reason we were producing seizures was to get the brain to stop them. That was also, I think, conceptually an important contribution because the focus of the field through the 40s and 80s was on the biochemistry that occurs during the seizure itself. And the state of the brain following the seizure was really not looked at consequentially. And so it does prolactin release during the seizure, does it really, and many things. And so the discovery that ECT was an anticonvulsant, that it induced slow wave activity, delta activity in the EEG, which also covaried with efficacy, that it resulted in an inhibition of glucose metabolism. And even though CBF goes up 300% during the seizure, it's below baseline following it. That all was consequential in my theorizing. Nowadays, and I would criticize our field strongly for this. The term neuroplasticity is the explanation we always give for why things work. It's because we're impacting on neuroplastic processes. That's sort of like insight in psychoanalysis. It's sort of like a meaningless.
Yeah, it just means something has changed. Okay.
It just it was ECT is the strongest promoter of neurogenesis of any intervention we have. Right? We did the work in primates demonstrating that ECT promotes the development of new neurons, functionally active new neurons. But that process takes months to become functionally relevant. And it's totally out of the time course of ECTs. You get a single one treatment and you're getting almost a 30% improvement in depressive symptomatology on average. And certainly the time course that you would take for having the full neurogenic effect. Now, it could be certainly other aspects of neurogenesis, many other aspects like synaptic density and have a very different time scale. But we have no idea at the concrete scientific level what aspect of brain change is tied to the efficacy of this treatment, particularly in the long run.
So let me ask you two more questions to wrap up this part, and the second one I think we'll set up for the TMS discussion to come next. And they're related maybe. The first question is, in general, across brain stimulation, but this is true for ECT, the stimulation changes so much in the brain, right? You zap, this goes up, that goes up, blood flow goes up. Therefore, there's going to be a response in this way and that way. And the risk of that is it may be the case that almost anything you look for will change. You'll look for this, you'll look for that. GABA goes up, glutamate goes up. And so on the one hand, you're finding all these mechanisms, on the other hand, you see my concern. It's hard to understand where the specificity is because again, you produce a seizure. I'm pretty sure everything changes. And
Yeah,
then, and maybe also just tie that to the second question, which is where I want to end up is it the seizure or is it the electricity?
um, in terms of the first question, it was that's the hopelessness that Seymour Ketty expressed very famously, and I've written somewhat about it. Ketty was one of our great psychiatric scientists of all time. He was the one that invented the Ketty-Schmidt method, which was the first method we had for measuring cerebral blood flow in the human being. And I won't go through it, but it was essentially you had anesthesiologists that were doing very invasive things to the carotid artery and the other art in order to measure in the whole brain. And by the way, the first group of humans that were studied with it were patients getting ECT, patients with schizophrenia getting ECT, where he demonstrated reductions of blood flow uh, with the Ketty-Schmidt method. Ketty then went on to do the first twin work in schizophrenia. He was also one of the groundbreakers in discovering the catecholamines and their role in the brain. So Ketty was a brilliant, expansive mind in our field. And his
By the way, it's so common in general in science when you have someone who's such an original thinker, the hits just keep on coming. You know what I mean? It just you get this like trail, and they're not even necessarily in the same domain. They just seem to the way their mind works. But yeah, go ahead.
very generative, yeah. And Ketty said at a conference that was, the a book came out if it was in Puerto Rico, the conference, that ECT does thousands of things that are consistent to the brain. And that the idea of ever figuring out what's epiphenomena and what is matters for efficacy is hopeless. He's essentially expressing the view you just did. And my retort to that was, well, we now have the possibility of using forms of ECT that don't work and versus forms of ECT that do work. And that subtraction is fundamental to our figuring out mechanisms.
Mm.
And so that was one of the great contributions of the low dose rate unilateral forms of treatment because when we reported in JAMA Psychiatry what the physiologic differences were between people getting well and not well, it was between ineffective treatment and effective treatment. I don't believe, for
By the way,
instance,
and the ineffective was also producing seizures, so it was not just that.
right, it wasn't just that, right? It was we conservative criteria for what constitutes a seizure, but and I argue that if you give Haldol or risperidone to people, the amount of D2 receptor blockade that they're going to get is going to be totally independent of whether the drug works or not. For some, it's going to be relevant to their pathophysiology. For others, it's not. But when you give powerful treatments, the idea that they're going to work differently in different people and that's 95% of our mechanistic studies are correlations between outcomes and some biological measures in people who receive very powerful treatments. And so that I think you have to weaken the treatment in strategic ways or change the treatment in strategic ways to ask the mechanisms of action of that treatment. Otherwise, we're just doing correlational studies with what gets better in people who get better or not. And it could be it could be many other things. So I think we've had that opportunity. Part of the reason that there's very little ECT research in the world, far less than there ever should be. I mean, unfortunately, there's a dearth of it. And on top of that, to be able to do experimental forms of ECT and to use it in a way that is not going to be as effective and so on. So you can see what the limitations are pursuing that line of thought. The other big limitation is there's no good animal model for dosing in particular. You cannot find the seizure threshold of a rodent because I spent 2 years trying to develop models where we could do this in rats.
Yeah.
And they have many seizures, so which are dosage related. So that, for instance, when you do kindling, there's
Yeah.
there's a scaling of the seizure expression with the kindled stimulation. And so you can't say, at what level did I get a seizure or not, right? And if you get one, then you can't try again. So nobody has effectively, the human is much more simpler. So is the monkey, by the way. Monkeys are incredibly reliable in terms of what their seizure thresholds are. And like the human, and it's almost all or none because you get this propagation to the motor cortex and you see it. In other animals, it's more complicated.
Sorry, I got it. You said something here. I need to take us a little bit on a tangent here. You talked about kindling and so the concept that you could use electrical stimulation, sometimes above seizure threshold, in order to make the animal more prone to now epilepsy.
Right.
So then you say, oh, therefore can intense electrical stimulation, but that's not what we see in people, right? In fact, if anything, we see the opposite, right? That it's anticonvulsant. So there is a bit of it's, it's kindling in animals, but
If
the
you give,
opposite in
if you
people.
give ECT to an animal before you kindle them, that
Oh.
you block the ability to develop kindling. So it's like many processes where once you exceed a threshold, it becomes a very different phenomena than below that threshold.
So you need to get to the seizure for it to have the anti, if you just, there's a
Right,
risk. Oh,
right,
interesting.
exactly. That at least in my theorizing, the seizure triggers the process to shut itself off, and you don't get that necessarily with just intense electrical stimulation.
Okay. And then the second part of the two-part question, and this, we're not going to wrap this up in this part, but I just want to get the
Yeah.
juices flowing, and then we'll get all into TMS and other things at the next part of this interview. Is it the electricity or is it the seizure? Meaning, if you could, you certainly classically, right, you can produce seizures without electricity and get some of the benefits. So that might argue it's the seizure. Alternatively, is it a crazy idea to suggest that you could just apply electricity and not produce a seizure and still have antidepressant effects?
I think both are true. I don't think, and this again, I think very narrow thinking that has to be one or the other was what produced the warfare between the ECT world and TMS world and the rest of brain simulation. There's a very cold reaction to the development of TMS by much of the ECT world, not because it was necessarily competitive, but it was ideologically heretic. And in fact, at one meeting of the ECT Society, essentially ISEN at the time, I think it was ACT then, Mark George was left out of a meeting because he was suggesting that non-convulsive stimulation of the brain could have antidepressant effects. In a more nuanced way of thinking about it, I developed a technique called focal electrical administered seizure therapy, FEAST, right, which aims to essentially spatially target the electrical for ECT. But that I was funded by NARSAT for Established Investigator Award for FEAT, which is without the seizure, focal electrically administered therapy, right? Uh, and it's quite clear that intense electrical stimulation does many, many things that could be therapeutic in the brain. And as one example, ECT is anti-Parkinson. There have been sham-controlled trials where it's quite clear that you get a reduction in the motor disturbance of Parkinson's disease when you deliver ECT. And at one point in time, before the more widespread use of clozapine, maybe 20, 30 people a year were referred to us at Columbia for ECT, but part because they were psychotic from their drugs. Right, the L-dopa and the dopamine agonists, and you couldn't give them antipsychotics. It was thought because of the dopamine blockade, you would Parkinsonize them worse. So ECT was the solution because it was both antipsychotic and anti-Parkinson. Well, it turns out that if you do microdialysis of the rat brain, you see that ECT results in a massive release of dopamine, among other things, in the basal ganglia. But what you do is if you block the seizure with a barbiturate and do the same simulation, you get the same amount of dopamine release. If you turn the dial up, you get more dopamine release. And I use that clinically when treating these patients with Parkinson's disease because it was, I turned the dial up and the patient would come back and say, whatever you did last time, it lasts twice as long in terms of my motor symptoms as. So there, I think the electricity has a great deal to do with clinical impact. That doesn't mean that the seizure also doesn't
Yeah.
have have its own levels of contribution. And so I've always been sort of the mind that it doesn't have to be one or the other.
Okay. So I like that. Let's leave it on this feat,
Yeah.
this strange idea of focally administered electrical therapy. That's going to set it up for the next part where maybe we'll talk about the birth of TMS, as you're saying, almost like in the shadow in some extent, or in whatever it is of ECT.
Right.